Neurology Quiz number 94. Describe the etiology, clinical features, and treatment of tardive dyskinesia or TD. The DSM-5 defines TD as a movement disorder developing in association with the use of a neuroleptic medication for at least a few months. By definition, it should persist for more than 4 weeks after the discontinuation of the medication. The duration of exposure is variable and can vary from a few months to a few years. Tardive dyskinesias are usually oral, buccal, and lingual movements and can vary considerably in severity. Etiology: TD is usually caused by dopamine receptor blockers, most commonly first generation and to a lesser extent by second generation neuroleptic medications. First generation antipsychotics are dopamine receptor antagonists or DRAs and are known as typical antipsychotics. They include the phenothiazines such as trifluoroperazine, prochlorperazine, triflupromazine, the butyrophenones like haloperidol, thioxanthines like thiothixine, and other medications like pimozide. The second generation antipsychotics are serotonin dopamine antagonists and are also known as atypical antipsychotics. These include risperidone, olanzapine, quetiapine, aripiprazole, and clozapine, among others. Another common causative medication is metoclopramide. Uncommon causes of TD are tricyclic antidepressants, SSRIs, anti-epileptic medications, lithium, and stimulants. The average prevalence of tardive dyskinesia is about 20% of all patients treated with first-generation neuroleptics. Atypical antipsychotics have been associated with a decreased incidence of TD and other extrapyramidal side effects due to their lower affinity for D2 receptors and the concomitant blockade of serotonin receptors. The currently accepted hypothesis for causation of TD is that in some patients, long-term exposure to DRAs causes an increase in D2 receptor or in their sensitivity. Factors increasing the risk of developing TD are age, duration of DRA use, history of drug or alcohol use. Women and African Americans or Asian Americans also have a higher likelihood of developing TD. Clinical features: most patients have chronic psychiatric disorders, primarily schizophrenic disorders or bipolar disease. The onset of TD is insidious and it can manifest as early as 1 to 6 months following the initiation of a DRA. TD is defined by the presence of chorioathetoid movements, which most commonly involve the tongue, lips, mouth, and jaw, and cause chewing movements, tongue writhing, often with protrusion, lip puckering, and lip smacking. It may also cause choric and athetoid movements of the limbs or trunk. Respiratory changes may occur, causing huffing, hyperventilation, or irregular or loud breathing. The Abnormal Involuntary Movement Scale, or AIMS, is a standardized scale to quantify the severity of the abnormal movements. It can be used to measure and follow the severity of the TD movements. TD is irreversible and persists after discontinuation of the offending medication. However, rare cases of reversible TD have been described after short-term exposure. This picture shows some of the abnormal movements in TD with pursed lips, puckered lips, tongue protrusion, and a twisted tongue. This is a brief video showing some of the abnormal movements in TD. This figure shows the abnormal involuntary movement scale used to quantify TD. Other tardive syndromes that can occur in association with long-term use of D2 receptor blockers include the following: tardive akathisia. This mimics acute akathisia, causing a sense of uncomfortable restlessness, leading to continuous voluntary movements to relieve distress. Tardive dystonia. Dystonia may be focal and restricted to the neck, jaw, eyelids, or a limb, or it may be generalized. Tardive myoclonus. This is rare and most commonly affects the arms. Tardive tics. Vocal and motor tics can occur that may mimic Tourette syndrome. However, this condition is of late onset and there is a history of exposure to D2 receptor blocker drugs. Treatment. As TD is caused by dopamine blockage, gradual removal of the dopamine receptor blocker should be considered. However, quite often DRB agents cannot be removed because of the underlying disease. In such situations, alternative medications include quetiapine and clozapine, which are less potent dopamine receptor blockers. This requires coordination with the treating psychiatrist. Medications. Two drugs, Valbenazine and Deutetrabenazine, are FDA approved for the treatment of TDs. Both are related to tetrabenazine and are VMAT2 inhibitors, which reduce the incorporation of dopamine into vesicles, hence reducing dopamine stimulation. One of the drawbacks is the high cost. Valbenazine dose is 40 to 80 milligrams per day and deutetrabenazine is 12 to 48 milligrams per day, given in 2 divided doses. Side effects include somnolence, fatigue, depression, akathisia, and QT prolongation. Tetrabenazine, which is approved for Huntington's disease, has been used off-label for the treatment of TD. Other drugs have included clonazepam, amantadine, and ginkgo biloba. Focal tardive dystonia can be treated with botulinum toxin injections.